Um, Thank you very much for inviting us to come to Hangzhou to the United Nations World Data Forum. It's very exciting for us. I'll introduce AfroPHC in a minute. I'm Richard Fitton, a retired family doctor, and I've been working with digital patient records for nearly 50 years. I'd also like to thank the technicians who've been very helpful, and Melon, and also Health Information for All, who's an international organisation, altruistic organisation, interested in making information available to all patients and professionals of an accurate nature across the world. And also to the Record Access Collaborative, which is no longer existent, which was very important 15 years ago as we developed record access for patients to the medical records in the United Kingdom. And finally, to the Albrecht Centre, St. Petersburg, for Disability and Impairment, who have been helpful in the last 10 years, as we have discussed the methods in which we could help patients with disability impairments get access to their data. I will just ask everybody in the audience, which isn't a large number of people in the audience, how many of you, if you can put your hands up, if you actually already have access to your own health data? Do any of you have access to your own health data? Okay. I mean, in England now, 50% of the population have access to their own health data. They use the National Health Service application, and they can access their own health data, their results, their tests, their correspondence. I think that's going to be an important part of the process of information governance. If you're going to use people's personal health data for statistics, I think people should be able to see what the data is. Because we've actually taken people from different parts of the world, some of the presenters may or may not actually have connectivity during this presentation. So Norbert, I'm afraid, from the Cameroon, has given us a presentation of the study he did, but at the moment he can't connect. So we're going to play a recording when we come to him of a presentation that he sent us about his collection of data about patients with disability during the COVID epidemic in Togo, Cameroon, and one other country. So thank you again for attending. Thanks for inviting us. I'm now going to introduce you to AfroPHC, who's going to moderate the presentations. Okay.
Thank you, Richard. I'm Ephraim Sinchri. I'm a nurse and academic editor from Ghana. Thank you all for coming. In this workshop, we will cover inclusion of citizens, children, families, disabled persons, and primary healthcare team in the world data cycle. And we will ask the UN to support a global personal health data processing standard. So, our main objectives are to demonstrate a wide range of personal health data processing systems, to ask the UN to support the development of global personal health data processing information governance standard. And we'll have some questions and answers. So, I'm the first presenter, and I will be presenting on use of digital health technologies in primary health care system in sub-Saharan Africa. Digital health technologies have become increasingly a commonplace of delivering primary health care globally, and it has been theorized that it reduces inequalities, increases access, and also strengthens health system. However, its implementation in sub-Saharan Africa is a challenge. So in this study, we explore the experiences of primary health care practitioners using digital health technology in Africa. A qualitative approach was employed using a Zoom meeting, and participants were recruited through Africa Forum from Primary Health Care and their contact networks using a convenient sample. They were included in the study if they have experience using digital health technology in sub-Saharan Africa, and focus group discussion and interview were conducted respectively in November 2021 and January to March 2022. Topic guides were used to cover relevant topics in the interview and focus group discussion using the SWOT framework, and transfer a compact verbatim using thematic analysis to identify emerging themes. To ensure standardization, the consolidated criteria for reporting qualitative research checklist was used. So the results. Some of the strengths identified include digital health technology improves access to care, it supports the continuity of care and increased care, it provides satisfaction and trust among users and providers, and also fosters greater collaboration among users and providers. It also enables safer decision-making in the health system and also hastens progress towards universal health coverage. The weaknesses identified include poor digital literacy among both providers and users, health inequalities, lack of human resources, inadequate training, lack of basic infrastructure and equipment, and poor coordination when implementing digital health technologies. However, some of the opportunities identified include it improves digital literacy, it increases equity, promotes more patient-centric design when in upcoming digital health technologies, and also it streamlines healthcare resources expenditure, and also it provides a means to learn international best practices. The threats identified include there was lack of buy-in from both patients and providers, insufficient human resource and local capacity, inadequate governmental support, and overly restrictive regulation from government, as well as lack of focus on cybersecurity and means for patient data. In conclusion, the research highlights the complex challenges of implementing digital health technologies in sub-Saharan Africa context as a fast-moving health-driven modality. Therefore, there's a need for multi-sector holders' involvement in implementation of digital health technology in Africa. We recommended that in order to implement this digital health technology in Africa, stakeholders have to improve analytical skills of staff to appreciate data, as well as to explore the challenges of these findings across different technology settings across Africa, on implication on health and healthcare equity, and also capitalizing on mixed research methods to understand patient health needs. My key message, without patient or professional digital literacy assessment, implementation of digital health technology in Africa cannot be realized. Thank you. So our next speaker is from Russia, the Albert Federal Scientific Center of Rehabilitation and Disabled. She is Yanina Bestrinova, and she'll be talking on evaluation of rehabilitation systems in Russian regions, indicators and trends. Yanina, over to you.
Hello. I would like to present some facts about rehabilitation for persons with disabilities in Russia. Can you see my slides? Yeah, thank you. More than 10 million persons with disabilities live in Russia in 83 regions, and among them, 700,000 children with disabilities under the age of 18. As a national policy aims to integrate persons with disabilities into society through providing equal access to assistive technologies. However, it rather focuses on needs of persons with disabilities than provides their capabilities. Next slide, please. In Russia, the rehabilitation process has some levels. At the federal service, a person can get a status of a disabled person. The personal data on disabilities and needs are entered into the Federal Register of Persons with Disabilities. On the level of the community, A service provider develops an individual rehabilitation program and delivers rehabilitation services. Next slide, please. 6 years ago, the Ministry of Labor and Social Protection of the Russian Federation approved the methodology on assessment of a regional rehabilitation system. It is a scoring of 4 indicators. Next slide, please. 3 of them characterize resources of the rehabilitation system: an integrated approach to rehabilitation, staffing, and digitalization. And one more indicator reflects feedback, namely satisfaction of persons with disabilities with rehabilitation. The next one, please. The final point score shows if the regional rehabilitation system needs to be improved. Next slide, please. Now you can see the indicators of all regional rehabilitation systems from 2018 to 2020. The second indicator of satisfaction of persons with disabilities increased and has a high average value of 1.57. Next one, please. Here, the second indicator demonstrates the trend of continuing digitalization in rehabilitation. The next one, please. Based on the final scoring, there was a significant improvement in the development of rehabilitation systems in Russia. But 40% of the regions has no clear programs on how to build the rehabilitation systems to meet needs of persons with disabilities more effectively. And the conclusion, please. Summing up, you can see implementation of the simple tool that helps to analyze development of a rehabilitation system and find a way to balance the capabilities or needs of persons with disabilities and resources. Satisfaction of persons with disabilities or their guardians with assistive technologies reflects their inclusion in the world data cycle. You can read more about the tool and findings in the paper by Alexander Shashmin, the next speaker, Christina Petrisheva, and me, published in the Society's Journal. And the last one, please. So I can thank you for your attention.
Thank you, Yanina. Our next speaker is also from Russia. He is Alexander Shomin, the head of Department of International Classifications and System Rehabilitation and Habilitation. He will be talking on data flow and records access in early intervention for children and their families. Alexander, over to you. Hello, Alexander.
In the family and it's look for information what and how can help. It's fine if these are organized sources, if they are health services, but they can be random sources. And here the organization of access to information for parents is important. It should be clearly structured and accessible as possible for people with or without education. Next, please. And then the person gets out of the house of the early intervention system. The initial diagnostic begins. Specialists face a problem of previous data access which the family may have. The data can play a significant role in determining early intervention route. At the first stage, specialists look through everything they available, analyze document, interview parents, examine the child, determine the scope of the problem, if it's her case or not. If a good advanced enough or an advanced diagnostic need to be conducted. It's important not to miss anything, and the psychosocial model can be the basis for structuring this process. Next, please. At this stage of the primary diagnostic, we identify deviation in terms of the ICF employment in some domains. With the advanced diagnostic, we specify ICF categories where impairments are identified. We should explain to the parents what we noticed. They need to look at the test result. Data should be accessible and easy for understanding. Algorithm based on the ICF category help is used in goal setting for the rehabilitation or the early intervention. Specify the intervention that are necessary for the child and the family and access the result. First of all, we have to discuss with parents what has the highest priority for them, what rehabilitation goal we are setting up together. The main thing is not waste time, to not lose faith in parents that something has the done together. Next, please. We agreed with the parents, however, often intervention can be provided in different organizations by different specialists. They also need to agree among themselves of the rehabilitation goal on their coordination. A common information space, not a set of corporate date, is feasible. Next, please. At each stage of rehabilitation, information is multiplied. Checklist, videos, conclusion, access to information is required through the parent's personal account. And next, please. And then we can reach the largest goal. A parent's child turn from the recipient of service specialties God make my child is astronaut to the active player. Together we will do all the best for my child. We have achieved something in the rehabilitation process of the child. In the most case, the process and the data flows do not stop. The rehabilitation cycle continues. Next, please. Speaking about the early intervention, the transition to the next level, for example, to the education system, is extremely important. The number of participation is increasing. A standard for working with personal data of the child and the family is necessary. At this stage, we can get the maximum result for the child only with the largest involvement of the family in this process. This requires access to the information, both the specialist and, of course, for the family. We built such of information system is one of the regions covering about 40 organizations, facilitating the work of specialists and the participation of family as much as possible. A personal account in this system plays a big role, but many problems remain. How to translate information from the languages of specialists to easy languages? To what extent to provide access to the information, to whom the provide access, how to share the data, access only for specialists, for ethical reasons, and open for family, etc. Next, please. Thank you for your attention. Next. Thank you.
Thank you, Alexander. Dr. Eshiba Matthew. She is a professor and director from Pushpagiri College of Medical Institute of Medical Sciences and Research Center from India. She'll be talking about patient data sharing, the stakeholders perspective. Eshiba, over to you.
Thank you, Ephraim. Greetings from Pushpagiri Center for Evidence-Based Practice, a JBI Center of Excellence, Kerala, India. I am L. Shiva Matthew, a public health specialist, making a short presentation on patient data sharing, stakeholders perspective. The others in my team are Sunu Alistarian, Nisha Kurian, and Vijay Lakshmi. Let me first introduce the Indian healthcare system for ease of understanding. We have public, private, and alternate systems of medicine. Public system has primary health centers, sub-centers, and upgraded primary health centers, totaling to a little less than 2 million centers as primary contact centers in the whole India. Then the secondary and tertiary centers. From the time I can remember, outpatients had their data on paper, retained by themselves, and inpatients' records were managed in hospitals with only discharge summary with the patients. Private system had outpatient and inpatient data at the center, with discharge summary shared and other records shared only if requested for. The alternate systems like Ayurveda, homeopathy, yoga, etc. come from Ayush division of ministry. Next slide, please. And the next now. Next, please. Ayushman Bharat National Digital Health Mission was launched in 2020, introducing shared digital infrastructure called National Health Stack. Hospital records are now going electronic or electronic with paper, but not shared, except summaries or on request as above. In non-communicable disease clinic, data is partially shared on paper. COVID brought in e-health for ease of consultation, a teleconsultation mode. As for public health, in some places, patient data is entered on a GIS tracked tab by the grassroots level nursing staff. Some of them run ANM ATM health service, a liaison between doctor and community patients. But this also has not reached the level of data sharing. Next slide, please. A preliminary investigation was conducted among physicians and patients through qualitative interviews. The summary of elicited opinions is presented here. It is clear that digital mission and data sharing will get instituted. Doctors welcome it and patients have no objection but are not much bothered still. But in such a vast country like India, with a large multicultural, multilinguistic population, having varied literacy, inadequate manpower, facilities, and remote villages and tribal areas, it is going to be a big challenge. Next slide, please. In the robust PHC system, electronic data and data sharing can be useful for safe records and portability at different levels, places, and service points. But the clinicians with poor typing skills lose on their clinical time and quality of documentation. They consider their training and facilities inadequate to cope with the expectation, like seeing 200 to 300 outpatients a day. The patients lack understanding and may even misuse the shared data. Next slide, please. Availability of archived information at one click helps faster decision making, and population based health data provides research database. But non uniformity of data format and uncertain electrical and internet continuity can be a major threat, so also the safety of sensitive personal information. Coming to a few recommendations, one physician recommended that the government could provide the format for data documentation and software for sharing to ensure uniformity and ease of operation. The physicians strongly recommend nationwide training for all stakeholders as early as student period, just like a digital language. Then, provision of support personnel for documentation. Then, community help desk for patients who are not able to use the shared data by themselves. Thank you for your patient listening.
Thank you, Esheba. Our next speaker is Oliver Crowton, and he's a patient, and he will be sharing his experience on no longer a passenger, using my clinical data from health service provider. Audio, please.
Hello, my name is Oliver Crowton, and this is an article that I sent in that went into the British Medical Journal. It reads, I read with interest the recent editorial on implementing person-centred approaches, BMJ 2017. I must first of all clearly state that I am neither an academic nor a health professional. I am a builder with a chronic disease, ulcerative colitis, that I have lived with for the last 5 or so years. I am also aware, to an extent, of the pressures facing the NHS and the medical profession. Only what I see in hospitals that I visit and hear through mainstream media channels, but enough to understand that to succeed, the system needs to evolve, and I think that person-centred care approach is a positive step. It is encouraging to hear of building communication and relationships between healthcare professionals and the people receiving care, as this can surely only serve to improve engagement and mutual understanding. The healthcare professionals' understanding of the patient and the patient's understanding of their condition and treatment. I do, however, feel that in an organisational and system context, as well as a patient context, the article neglects to acknowledge an extremely valuable tool, that of the ability to share patient data. I refer not only to the appropriate and controlled sharing of patient data within and across relevant organisations, which has its own merits, but also, and importantly, the sharing of patient data directly with the patient to which it relates. During the years following my own diagnosis, my relationship with my healthcare professionals, doctors, nurses and consultants, has quite suddenly and accidentally become more patient-centred. 2 years ago, I was at a stage in my understanding of my condition and treatment that was so limited it placed the entire weight of responsibility for my care on the doctors treating my condition. At that point in time, I had lived with my diagnosis for 3 years and I was a passenger along for the ride, feeling I did not have a part to play. Quite by chance, I was then offered the opportunity to sign up for digital access to my records through Patient Access by EMIS. I have found that access to my medical data, including test results, consultation details, diagnosis history, etc., has empowered me as a patient and given me a platform for the sort of communication with my healthcare professional that person-centred care appears to seek to achieve. I ask questions, discuss options for treatment and associated side effects, as well as assisting with the management of my regular scheduled treatments. I am able to feel a better level of care with less contact with the surgery. I can manage prescriptions and view test results without the need to take up time talking to surgery staff. I can review treatment dates to ensure that my blood tests and treatments are scheduled appropriately without the stress of wondering when they are due. The access to EMIS has allowed me to take some ownership of my condition and to work proactively with my various healthcare professionals in the management of my disease and its treatment, both short and long term. I have no doubt that I would not have the confidence required to begin discussions with my doctors without the access to my records as a basis for communication. I find the quarterly visits to my consultant at hospital are also now far more useful. I'm able to discuss the results of my GP surgery visits and test results and draw directly upon them at the consultation from my smartphone if required, adding depth to our discussions. In short, I am no longer a passenger. I am now very much a part of the management team for the effective treatment of my condition, and I am pleased to say that I am managing to remain in good health. I understand that not everyone will have the capacity to use their data in this way, but there are very many who will, and I can see access to patient data being a very powerful tool indeed in achieving patient-centred care. Thank you.
Dr. Brian Fisher is a clinical director at Evergreen Life and a GP for more than 42 years. Brian will talk about harnessing record access for health. Brian, over to you.
Thank you very much. Yes, I'm Brian Fisher, family doctor in London and clinical director of 2 companies, Evergreen Life and Optimize BP. Thanks to Oliver for showing us how access to your health records can put you in more control of your health and healthcare. I want to show how we can harness that access to do even more for people's health. This is the home screen of our app Evergreen Life, available to everyone in England with over 1 million users. It enables people to access their GP record just as Oliver described. It also harnesses that access to help people stay as fit and well as possible. You can see that it focuses on food, fitness, and happiness. It combines access to your GP record with a personal health record, which is where you can store your own health information. Put together, this means that people are able to take more control over their health and healthcare, and we also enable research and can help people improve their health behaviors. Next slide, please. Here is an example of Evergreen asking questions about happiness in this case. And the next slide, please. And when the person has answered all those questions, you can see that they get a personalized report on their state of health and how they can improve it. This is done across many dimensions, food, fitness, and so on. And we can harness information that people have given us and information from the doctor's record to improve our responses to them. Next slide, please. Here is another important development that Evergreen can offer. Here, we will be working with people with high blood pressure to help them stay as fit and well as possible, maybe reducing their medication, or maybe even able to stop their treatment. We're able to provide personalized advice based on their personal health record and their doctor's record. And this process can be extended to other conditions, such as diabetes. Next slide, please. Here's another development. Pictures of skin problems are taken by family doctors or by patients and are sent with a detailed set of answers to a questionnaire about the problem to specialists online. The specialists review the pictures and make a diagnosis. If they can't make a diagnosis, they'll see the patient. This process has reduced waiting times from 2 months to 2 days. Next slide, please. By using our app in family doctor surgeries to respond online to patients' queries, we've been able to shorten response times dramatically. Most requests are dealt with on the same day, and staff and patients are very happy with the approach. Of course, things can still be done in the face-to-face way if needed. Next, please. This is another development. This is for people without diagnosed high blood pressure. We ask them to take their blood pressure at home or in a pharmacy. They can add the blood pressure to the app, which then gives them immediate feedback about their level. It also passes the data onto the practice, which can respond appropriately. We know that we as the NHS as a whole are missing perhaps a third of people who have high blood pressure, but unknown to them. So this is a way of finding and beginning to treat them where necessary. Next slide, please. And the last one. I'm also director of another company called Optimize BP. We automate the management of blood pressure. The clinician says which medication is needed for that person and what increasing dosage steps are needed. And then the app takes the patient through the changes, asking about side effects and arranging blood tests when needed. We expect that this will save a lot of time and offer safer care. So I hope that you can now see how health IT can improve care and make life better for both doctors and patients. Thank you very much.
Thank you, Brian. We have Norbert Chofi from Pan-Africa Institute for Development, Cameroon Regional Institute for West Africa. Norbert will be talking about science policy data interface for responding to COVID-19 in Sub-Saharan Africa. But for some reason, he can't join us, so we'll play the audio. Norbert.
Hi, all. I'm highly delighted to share with you my speech on science policy data interface for helping disabled citizens to respond to COVID in Sub-Saharan Africa and the development of community-based traceability application for disablement. The outline consists of introduction, objective, key finding, lesson learned, and conclusion. Regarding the challenges, we carry out study in 3 countries, namely Cameroon, Togo, and South Africa, and the challenges seems more or less similar with slight difference. We interview 15 out of 20 for Cameroon, 12 out of 20 for Togo, and 14 out of 20 for South Africa. The objective of our study was to discover the necessary requirement to help disabled people respond to COVID. As method to use online data collection and through survey and scorecard. About the survey, as I mentioned before, we carry out a study in 3 countries. And as a result, 2 over 400 were affected by COVID in Cameroon. 3 over 80 disabled were affected for Togo, and 16 over 120 were affected in South Africa. As key finding, as we predicted with TOT model, we obtained 2% for Cameroon, which is more or less close to the 3% we predicted. We obtained 3.75%, which is close to 4% predicted for Togo. We obtained 33% for South Africa, which is close to the 77 predicted. As key finding, the TOT model allowed to predict pandemic spreading within a community as shown in the table 2. It is a catalyst of change which confront theory and practice. All results predicted are almost close to the final result obtained at the 3 disabled center. The TOT model could help to trace visual disabled movement during crisis. The COVID crisis has made life worse for people with disabilities. According to the study carried out in the 3 countries, during lockdown, people with disability and their family found it hard to earn money and pay for enough food and medicine. Some people got help from government organizations. In case of South Africa, the COVID crisis changed how people with disability live. It is important that the government and all other organizations help people with disability during the COVID outbreak and future difficulty time. The lesson learned during the mechanism employed by people during disability during pandemic were using saving and business capital, reducing expenditure, support from friends. Lesson to be learned was the traceability application used by the people with disability during the pandemic. During this pandemic, some people with disability in Cameroon developed a self-awareness and strategy that could be scaled up in another country. They created a WhatsApp group with GPS to track and localize visually challenged during their movement. This network surveillance continues today to help those who miss their way. In conclusion, there's need to fulfill the human right of disabled people during after pandemic to capacitate them how to stay safe from sickness, respond to COVID, and to support them with all type of impaired function during crisis, to translate research into practice with TOT model, to prioritize assistance to the vulnerable community during crisis, to work together in friendship with disabled toward a common purpose. Thank you for your kind attention. Hi.
Our last speaker, Dr. Richard Fitton, a retired medical doctor, will talk about information governance requirements for national and international personal health data processing. Over to you.
Thank you very much, Ephraim, and I hope the presentations are showing to statisticians some of the enormous difficulties and very long journeys we have to make to be actually reusing data in different settings. Brian Fisher was showing perhaps the most advanced system, and in England all patients are registered on a digital record and most have digitalized digital coded entries, and it's getting easier and easier to access that data. But in other countries using paper records or where there are difficulties with digital connection, that is different. as somebody who's been involved sharing data, and I was on the National Care Record Development Board for the United Kingdom and a guardian of data in a number of different situations, and also had a reasonable amount of correspondence with the World Health Organization about patients being able to see their own data. 20 to 30% of records are actually inaccurate or missing data when those records are actually seen by patients. Have felt for many years that we need to be working towards a common global information, personal health data governance standard, and I do think that's possible, or framework rather than standard. To have your data processed by a country, by a region, by an organization, or make it available to your own community because they work in your health center, raises concerns for all people, and trust in the system of recording data and shared data has to be earned, partly by feedback of how their data is used. I think especially by people being able to see the data that has been recorded, and I'm not hearing very much about that, but I think that's really important. Patients can be stigmatized by certain conditions, by disabilities, by impairments, and they may not want that data to be shared, or if it is shared, they want to be certain that other people don't hear about it. And of course, patients will have different political and religious views about certain bits of data. So I think if we do manage, well, we will manage to develop information governance structure, we need to have quite complicated talks, but also begin to develop templates so that we can look at which data can be shared under what circumstances and which can't. Information governance for personal health data should safeguard trust in the confidentiality of the system, and it should encourage safe information sharing for individual care. It should support understanding and engagement about data use. And this, I was delighted to see a wonderful video yesterday produced by Transform for Health, which explains in pretty universal terms to citizens or politicians or professionals why we record data and how we record data. There's very little of that done. And in England 20 years ago, the United Kingdom, £12 billion 20 years ago was committed to creating electronic digital record systems in England, and it failed for a number of reasons. Quite a lot of them I couldn't explain. But one of the reasons was we didn't develop a conversation with the public, with the different publics. We didn't talk to people, and we didn't involve them right from the beginning. So I think if we are, or as we are going to, process people's personal health data during a pandemic, we need to keep talking to people. There should always be a patient in the room, or there should be an equal number of patients in the room to the people actually making the decisions. And one of the little sayings in English National Health Service information technology is, nothing about me without me. And I think for personal health data, that's extremely important, that we need to be getting people involved in those conversations. We are not alone as a group of doctors and patients asking for a global information standard. And the WHO's Global Strategy on Digital Health 2020 to 2025, which is only 1.5 years away, recognises the need for international agreements and principles within 2 to 4 years. Those agreements may become available, but actually educating people and implementing them will take longer than that. There's a very good paper, if people are interested in looking at the possible future or the required future principles for processing people's data in different countries, in the International Journal of Health Governance Issues. And if people are interested, I really recommend reading it. One of the authors is sitting with a hand up here, and one of the other. But did Holly speak yesterday? No, she didn't. Did she, Louise Holly? I don't think she did. One of the organisers did speak yesterday. this paper, and it's not just a paper, it's a record of work that's been done with consultations with very global organizations, introduces a new set of equity and rights-based principles for health data governance, with a case for adoption into global, regional, and national policy in practice. And this has become so much more obviously necessary during the COVID pandemic, and especially in England, where there's a lot of differing views about privacy. But when COVID took place, people who previously didn't want to share their data, 1 million people every 3 or 4 weeks registered so they could actually share their data and have it used, and they could see their data as well. So more than 50% of people in the United Kingdom now theoretically have access to their medical data, and they're allowing people to contact them and message them through that system, which I think is fundamentally important in all countries if we really are going to try and have pretty fast responses to emergencies, pandemics, and general communication for public health. The principles that are suggested by the authors of the paper, and it's not just the authors of the paper, this is following a large consultation with many agencies, are clustered around 3 interconnected objectives. To protect people, citizens, to promote health value, that's to promote value in the health systems that are being implemented and put into place for people, and to prioritize equity. And I think we've already seen inequity today with the difficulty Norbert had from Cameroon to get on the internet, and I think that's really quite an interesting issue. And I think that's why health data governance is really important, because in those situations we have to have different solutions, because cybersecurity actually gets in the way of life. People die because there's no data available. The principles to protect people are to protect individuals and communities, to build trust in data systems, and to ensure data security. The principles to promote health value from the health data processing, to enhance health systems and services. And recently, the head of our NHS transformation in London was saying we need to take some risks. People who are very adverse to sharing on patients' behalf are actually making a decision about people's confidentiality without asking them. People who actually really want their data to be shared, the people who are responsible for making those decisions don't want to make the decisions on behalf of patients because they might get in trouble. And this is again why we have to have a conversation. And should facilitate innovation using health data, which is what many of the excellent statisticians here wish to do. To prioritise equity, we should promote equitable benefits from health data, establish data rights and ownership, and I've been very interested and involved in co-ownership. I think patients and families should have some ownership and responsibility and custody to some extent of the records, but also be able to validate that. You'd be surprised how many patients have got the wrong letters in their notes, and the only person that can check that is the patient themselves. I think that's an information governance issue. Finally, and then that'll just give us 10 minutes for any questions, if there are any questions. The paper and the work that's been done for the 2 years leading up to the paper speaks very strongly about representation and ownership. And the principles should be developed by traditional digital health and data experts and statisticians, but also by representatives of groups directly affected by health data governance, including youth, women, and marginalised communities. And I can say, quite honestly, that when I built a patient-centred medical centre, and specifically to give patients access to the records, we had a group with more patients in than we had professionals, and they helped design the system. So I really had very little worries about that. Last thought, we're teaching children, age 11, 12 and 13 in England. I'm giving courses of lectures how they can actually access their own records. How can we be assured that the data about us is being shared, that it's correct? And I would say by accessing and viewing our own records. And as I said, at the moment, 20 to 30% of records are inaccurate or have got errors in them. So thank you very much for listening to us. Ephraim, do you want to come up to the stage? And if there are any questions, if you want to just see if there's any questions from the audience, I'll have a look to see if there's any. There aren't any questions. Okay. Do you have any questions from the audience? If we don't, I've just got a few questions, and we can always finish. Was that hands up or just scratch? Oh, it was a hand up. That's scratching your head. There you go.
So, hello, thank you very much for a very nice presentation. Different work have been done in the progress in the United Kingdom as well. And I am a youth representative, so we're also working with youth innovation, data science, and how we can also having apps, modernizing the process of the whole. Is there any opportunity of youth inclusion, youth participation? I mean, now that you have mentioned about representation, about equity, about inclusion in data as well, and as well, could we implement it into a larger scale in the region as well as the region I'm from in the Asia and the Pacific of how can we share different good practices into the localization and implementation in other parts of the world as well? Thank you.
I'll answer that first. Firstly, it's lovely to have you in the audience. Thank you very much. And as a little story, we were in Uppsala in Sweden at a Patient Access to Records conference in November last year. And they're in a very strange place in Sweden that up to the age of 13, parents can see the medical records. Between the age of 13 and 15 years and 364 days, nobody can see the records. And at the age of 16, young people, the parents or the person can see the records themselves. It's really quite an interesting situation. I think it's essential youth get involved in this, absolutely essential. We did a survey, I didn't do a survey, some friends did a survey, undergraduate doctors, nurses, midwives and pharmacists, they're not being trained about digital health, so you should, and you're the generation that's really going to benefit. And in my mind, I mean, the technicians have been wonderful dealing with me. I mean, I'm really bad on technology. You're going to be able to use the technology really, really well, and you're going to drive it. I hope you're going to drive it. So I'm going to have a word with you afterwards, if that's okay, and we'll link in with you. I think it's very exciting. I think the transition from being a child, a student, to being an adult is such an important one when it comes to relationships, employment, the community, sexuality, contraception, and you really need to have access to that information, and you need to be involved. A friend of mine has produced a patient portal, and he produced it for students. And he said, what do you think? And they said, it's rubbish. So he took it away, came back again, and they said, it's rubbish, let us do it, and we'll make it. And he's got a really nice portal now, which lets you see your own data, but it's designed to help you, get you on. So lovely to see you. I hope you have a word with me when we're finished. Did you want to say anything, Ephraim, about that?
No, I think we have said it all.
Okay. Any more questions? I'll just quickly
Can I say something about that?
So Brian, yes, of course. Yes, go ahead, Brian.
One of the problems in the UK is that the law around young people is quite complicated and is around their competence to understand what they might be reading. So it's difficult to give a blanket age to say after this age somebody will be able to look at their records after the age of 12 or 13 because different people mature at different times. So in the UK, that's one of the issues that we've been struggling with. And of course, in reverse, at the moment, parents can see their children's record as Richard has described it. But of course, there comes a point at which children have their own independent lives and their parents should not be looking at their records. And that's also an issue that's not legislated for particularly at all. So it's complicated. I agree with Richard's overall and the questioner's overall idea that young people must be involved. But it's not that straightforward.
We've got a couple of minutes left, and There's just a couple of questions I'd like to ask you as the audience. I've already asked you once, but I'll ask you again. Why, in the audience, somebody answer me, why have you not looked at your own data? And why, do you think you should see your own data, or you don't think you should see your own data? I'll ask the lady in the front. Oh, no. It's not fair. Sorry?
I think that's depend on the different system in different countries. And just for now, as for myself, up to now, I am keeping a health life, and I didn't check my
Yeah. Yes.
health data yet. But I think this this view or the topic today is very important.
Yes.
Because the data is increasing, and it's generating every day, and it's very important for us to have this harness of this data, and that will be useful if you make some analytical work on the trend, on the development of person, and give them how to say focus, give them a notice in the development in the future. It's very important.
Thank you very much for this comment. I agree with that completely.
Can I comment on that too? Sorry.
Yes. Yeah. Yes. Go ahead, Brian.
I think it's a very common feeling that you're young and fit and you don't need to access your records. What I was trying to show in my talk is that if you do have access to the sort of app that we've produced, then you can stay as fit and well as possible for as long as possible. That we can, in the future, we'll probably be able to show what your risk of high blood pressure is going to be, what your risk of diabetes is going to be, and it would, and also we enable, for instance, your genetics to be looked at, which also has an impact on your risk of illness in the future. So all of those things can be put together in a health app that links to access to your records. And the aim of that is not just to wait until you get ill and then you can have a look at your records. The aim is to try and encourage everybody to take control of their health and their health care, and to stay as fit and well as possible for as long as possible. We want to increase the number of healthy years that people have, not just the lifespan, but healthy lifespan.
Brian, thank you very much. We've had the 2-minute notice from the back. I'd really like to thank all the presenters. It's been fairly complicated and had a tremendous amount of help from the technicians in getting people to speak from different parts of the world. I think the final thing I'd like to say, especially with Kirsten sitting in the audience, is I hope over the next 3 or 4 years you will understand we do need to have a proper framework for sharing, for their benefit, patients' data. It's for direct care, it's for public health care, which is slightly different, so you need a different set of governance. It's for research and planning, and then finally for innovation. And I'm hoping we'll manage to get a framework for all countries to use. Thank you so much, everybody, for coming, and we'll finish there. Thank you very much indeed. Thank you.